Today we're going to be talking about medications for both weight loss and diabetes. There's some overlap between these, specifically with the GLP-1s. We're going to start with an overview of more of the diabetes medications, and then later on discuss the GLP-1s and the weight loss medications. Lifestyle changes are very fundamental, and these lifestyle changes like diet and exercise remain the first line treatment. Unfortunately, we know that obesity is a chronic disease, as is diabetes, and sometimes weight loss is not always achievable through diet and exercise alone. In those cases, we use some adjunctive treatments with medications to try to improve our patients' metabolic health, assist with weight loss, and improve overall quality of life. So just to remember that these are some tools to be used with the lifestyle modifications and not instead of them. So a broad overview, we'll talk about some diabetes medications, some weight loss medications, some previously used weight loss drugs, and then the very popular GLP-1s, and then what's also coming in the near future. As we talked about, sometimes weight loss is very difficult to achieve with diet and exercise alone, and diabetes control can be very difficult to achieve with diet and exercise alone. So for patients that have persistently elevated A1C, which is that marker of an average blood sugar over a 3-month period, or if they have other comorbidities or complications or health conditions such as kidney disease, heart disease, or other metabolic disease, they may benefit from additional medications, as well as patients who have obesity or are overweight with some comorbidities such as kidney disease, heart disease. They may also benefit from additional medications. And just as a blanket statement, every medication has side effects. So it's always important to speak with your healthcare provider prior to starting any of these medications, even though they are very powerful and they can really have a strong positive impact on patients' life. It's very important that every medication does have some side effects. I wanted to put this in here as well because we don't always think about food as medicine, but it really is. Anything that we put in our body can have positive and negative effects or side effects. So food also has side effects, and I just wanted to reemphasize that point. So making sure that we look at food as not just calories, but also something that fuels our body and they potentially can have side effects as well. Okay, so we're going to start with a few of the major diabetes medications, and the first one will be insulin. Insulin is a hormone that your body naturally makes. It helps to reduce the blood sugar levels and allows our cells to use that sugar as energy. Diabetes occurs when our bodies become insulin resistant and we're not really able to bring that blood sugar into cells. And so the blood sugar levels stay high for a prolonged period of time, which can lead to several complications. Insulin, basically, you can think of it as the key that opens the door to allow glucose or blood sugar into the cell for our cells to use as energy. This is a really important concept because a lot of the medications build upon this interaction, either by enhancing insulin sensitivity, meaning the doors are more receptive to the keys. It's like a better fit of the lock, pretty much, or you have more keys in order to open up more doors. That kind of locking key is a pretty simple understanding, but it does get the point across that it allows us to use the sugar that's in our blood. So this is a schematic here. These blue little dots are supposed to be sugar, and then you see this channel that has a block on it, that gray tube. That is the idea of a channel that allows sugar into the body, and then that red V is like a receptor or the lock on a door. Insulin would be the key. That's that kind of bluish green arrow. It allows the door to unlock and then allows the sugar to enter the body right there. There's many different types of insulins. There's some rapid acting, short acting, and then long acting insulin. There's many brand names out there. Basically, we try to cover blood sugar with short acting or rapid acting for that prandial, or meaning that mealtime blood sugar spike. And then we also use long acting insulin, which has a half-life or a duration of about 22 to 24 hours. And that longer acting one kind of mimics our body's normal insulin release. Some people are on short acting, some people are on long acting, some people are on a combination of both. I have a depiction of the duration here just to help visualize this, but different formulations of insulin have different durations of treatment. So that's why you'll see some people, or you may even use some types of insulin when you're eating. Those are typically the shorter acting ones, as we talked about. You can see that the time or the duration of action is much less than some of the longer acting insulins like Glargine or Lantus, which you'll use typically at night or once in the morning. Those are typically the once a day. Medications, insulin itself can cause hypoglycemia or low blood sugar, which can be very serious. So it's very important to continually monitor your blood sugars closely, either with pinpricks of your finger to test like the point of care glucose, or they now have glucose continuous monitors, which have been a game changer and help to continually monitor your glucose throughout the day. Another very great medication is an SGLT2 or inhibitor like Jardiance or Farxiga. These are very popular medications because of their benefits with the heart and the kidneys. They do allow a little bit of weight loss, like 3 to 5 pounds, and then can also sometimes benefit blood pressure to a lesser extent, but more they really help with diabetes. And they help with diabetes by inhibiting the reabsorption of sugar. So normally our kidneys do a great job of kind of reabsorbing protein and sugar back into our bodies, even when we have very high blood sugars. Sometimes if we have too high blood sugar, it spills into the urine. The mechanism of action of this medication is to increase the excretion of sugar into the urine so that it doesn't remain in our blood, and that will reduce our blood sugar. But it does come with some side effects. If you can imagine that you're having more sugar in your urine, that can sometimes lead to some yeast or urinary tract infections. It rarely can be associated with DKA or diabetic ketoacidosis. And so because of that, it's always important to monitor your symptoms. But overall, it has been shown to improve morbidity and mortality, meaning the quality of life and the length of life in patients with heart failure. And because that has such a large population, it's a very important medication. It's a very strong medication in terms of what it can do for the body, but it also has some side effects to keep in mind. Metformin is another very common medication. It can be used by itself or in addition to other medications. It is the first line medication that we use for diabetes. So you'll hear about it a lot. Many people are on it. It also is used off label for PCOS or polycystic ovarian syndrome. It can assist with insulin sensitivity and assist specifically in that population, which that can lead to the androgenic effects. So it's a great medication for a lot of people. It has a very minimal amount of weight loss or is like weight neutral, which can be positive because some of these medications can also cause weight gain. So it's like a fine line between balancing diabetes and also managing weight loss. Performance, just wanted to include that there because it is such a staple of a medication. And then we'll move on to weight loss medications and go over the history and some of the other medications that may have fallen out of favor and popularity. One that I like to talk about is called Orlistat, and you may have heard of Olestra, which in the 80s and 90s was the new thing. Everybody was very excited about this because it was a fat-free alternative that still gave that kind of fat taste. And it was used in one of their chips, and they advertised this as this fat-free chip, and this is all great. So you can have your chips and then not worry about the fat in it. However, it became apparent that the Olestra they used as that additive was very similar to Orlistat. And Orlistat works because it blocks the absorption of fat in your intestines. So you can imagine if you're not really absorbing that fat, it has to go somewhere and it comes out in your stool, and it can really cause a profound amount of loose stool, oily stools, bloating. It was taken off the shelves rather quickly because people were noticing this side effect that they were running to the bathroom, having accidents. It was a very short-lived craze, but Orlistat basically works by inhibiting the absorption of fat, and that's how it assists with weight loss. It's not very commonly used anymore due to these side effects, obviously. I don't think I have a patient on Orlistat. I probably would not. It would not be my first line medication to prescribe to someone, but just so you're aware that it exists. Another medication called phentermine. This is a stimulant medication that stimulates your brain to reduce the appetite. It's similar to an amphetamine, but much milder. It increases the adrenergic compounds such as norepinephrine, and that works to stimulate the body. Broadly thinking, we have these two modalities that our body is typically in, either the fight or flight or the rest and digest. And this kind of stimulates that fight or flight aspect. So it calms the food noise, decreases your cravings. Because of the stimulating effects, it really has a handful of side effects that are important. It can increase your heart rate, increase your blood pressure, so it should not be used with patients that have hypertension. It can lead to insomnia or decreased ability to sleep because it's a stimulant, so it's keeping you awake, and also can cause dry mouth. You can get a modest amount of weight loss between 5 and 10%, but it's important to know that this medication really is only used in the short term because of these side effects. So it's not a medication that you would stay on for a prolonged period of time, but you may hear about this medication because it can cause a modest amount of weight loss as well. I wanted to emphasize that when we talk about weight loss, everybody has a different goal, a personal goal that they shoot for, but we know that we would like to shoot for 5% of total body weight loss or ideal body weight loss, and that can allow your body to become more sensitive to insulin, and it can allow your body to have the positive metabolic changes. So you don't really need to have 20, 25, 30% weight loss to have metabolic health improvement. And I think that's an important point. The next medication, also not as commonly prescribed as topiramate, and I won't spend too much time on this medication, but originally it was an anti-seizure medication, and one of the side effects was weight loss, and that is due to decreased food noise as well. So it can be used off-label for weight loss. It should not be used in patients who are pregnant or may consider becoming pregnant because it can cause some birth defects. So it's always important to have be on at least one form, probably two forms of contraception while you take this medication. This next medication is a combination of two medications, naltrexone and bupropion. It's also known as Contrave, which is the generic form. Basically, it's a combination of the naltrexone, which is used for substance use disorder in some patients, as well as bupropion, which is an antidepressant, but also a smoking cessation aid. So you may have heard these medications used for different indications, but they found that combining these together can cause also like a modest amount of weight loss between 5 to 8%. It does this by working on the brain reward pathway to reduce hungers and cravings, similarly to how it does with substance use. So it reduces that reward feeling from eating. And we know that food in and of itself can be addicting to people. It really can ramp up that dopamine reward pathway. It has similar pathology to addiction in the sense that people are getting that dopamine rush, that reward feeling from eating, and then it becomes this habit that turns into something that you continue to crave, and that's that food noise. And it can really be stressful for people that really want to reduce the amount that they're eating, but their body is constantly telling them to eat. Even though they may be full, they're craving that dopamine feeling. It should not be used in a few sections of patients, including patients with uncontrolled hypertension or high blood pressure, patients that have a seizure history, if they're taking an opioid medication, because naltrexone inhibits some of that receptor. So you could precipitate withdrawal in those patients. So it's very important not to use with someone who is either taking opioids by prescription or who is using them recreationally or has substance use disorder. And then also to be used in caution with significant liver impairment. So you'll need to continue to monitor your liver numbers. This medication I'm seeing come back a little bit more because patients are having some difficulty getting the GLP-1s covered by insurance. This is definitely not as effective as GLP-1s, but it is an additional medication that can be used in the physician's toolbox to assist with weight loss, especially with patients that don't have the ability or access to take a GLP-1. Moving on to the meat of the talk here is the GLP-1 medications. So we'll go over a broad 10,000-foot view, and then we'll dive into different types of them. So what is GLP-1? It's glucagon-like peptide 1. It's a hormone that your body makes typically after eating. And the GLP-1 receptor agonist, or that GLP-1 RA, is a medication that mimics this hormone. That's that receptor agonist or that RA aspect. And it has a longer duration of action typically than the naturally occurring hormone that your body makes. It has several effects throughout the body. One is similar to those other medications that we talked about. It can reduce the appetite and cravings that you have for food. So if you or someone that you know is on this medication, you or they may say, I'm definitely not as hungry as I used to be. I can't really eat as much as I used to because I just really don't have that craving for that larger plate of food. And part of this is because of that brain effect where it reduces your cravings, but also in the stomach and in the GI tract, it decreases the transit time of food. So food stays in your stomach and your colon and intestines longer. This can make you feel more full for a longer period of time after you eat. So you're not going back to the fridge, back to the pantry as quickly, which also assists with weight loss. And then through the insulin, through more of the hormonal and endocrine pathways, it can help release insulin when blood sugar rises, and also can help increase the receptor responsiveness, the kind of key in the doors for insulin to have their effects. And GLP-1s are different than the the other medications that we talked about because they do work on multiple pathways and they definitely have a more significant weight loss. The older medications, anywhere between 5 and 15%, and the newer medications are up to even 20%. Additionally, there's some very large trials that have showed benefits from patients with kidney, heart, brain disease, like a prior stroke, and overall metabolic health and some sleep apnea, things like that. They're very good medications for a large population, and that's why they're becoming so popular. That's a Gila monster. The history of the GLP-1 is interesting. It was originally discovered in the 1980s when they discovered that our body makes this hormone and it's produced after eating, and it can help with our ability to produce insulin and respond to insulin. And then in the 1990s, there was a scientist that discovered the Gila monster actually has a longer acting version of this. And because of that, they started to think, okay, we know this medication can help reduce blood sugar. I wonder if this can be extrapolated to humans. And then it was put into the research trials, and the rest is history. The first GLP-1 was approved in 2005 for diabetes, and then the first GLP-1 for weight loss was approved in 2014, 2015 for weight loss. A little bit of a history lesson there, but I do think to have the background, it helps you have a better understanding of why these medications work and where they come from. So here is a list of the GLP-1 medications, the main GLP-1 medications, from the most weight loss to the least amount of weight loss. So the newer medications, tirzepatide and semaglutide, these are the most popular medications. You'll see a lot of commercials on the TV talking about Ozempic, Wegovy, Zepbound, Mounjaro. They do a great job advertising, and a lot of my patients will come in and say, hey, I saw these commercials. Is this medication right for me? And for many people, it is. It's a great medication. Most of these are a weekly injection that you put in your stomach, or you have subcutaneous tissue once per week. And some are a pill or becoming a pill, which is definitely a very attractive option for patients that have a phobia or are afraid of needles. Although I will say I do get that concern a lot, that patients are like, oh, I'm interested in this medication, but the idea of poking myself at home once a week really is a deterrent for me. But the needle itself is so small, and a lot of people do not even feel the needle. It's like a little bit of a pinch that goes away almost instantaneously. So I really try to push my patients, if they're a good candidate for a GLP-1 and they have a little bit of that needle phobia, to try it at least a few times, because a lot of them tolerate that without an issue. Tirzepatide is interesting because it is a combination medication. So similar to how Contrave was a combination medication, this is also a combination of GLP-1 as well as GIP, which we'll talk about in a little bit. So that's that Zepbound and Mounjaro. Has up to 20% weight loss at the higher dosages, and it is approved for diabetes, obesity, as well as certain patients with obstructive sleep apnea. Semaglutide, Ozempic, Wegovy, Rybelsus. This is another weekly injection. This one comes in a daily pill. Rybelsus is the oral version of this that was out previously, and then very recently, I think actually at the end of last year, early this year, Wegovy, or semaglutide as a whole, came out with an oral version, which is just a higher dose of semaglutide, and we'll talk about that in a little bit. So it's similar to Rybelsus, but it has a higher weight loss profile because it's at a higher dose. The other medications are also very effective, duaglutide, exenatide, and depending on a patient's insurance, I'll have them either start on one of these medications or they just permanently be on one of these medications because they're a little bit less costly. They still have very good profiles in terms of cardiovascular reduction and long-term benefits, but they do not always have the same percent weight loss. I try to get my patients on the semaglutide or the tirzepatide if their insurance will approve it, but if not, these alternatives are very good alternatives. If your healthcare provider is recommending that you be on one and you may not be qualified or you may not be approved for semaglutide or tirzepatide, it's still important to consider taking a different GLP-1 because of their positive effects outside of weight loss as a whole. We'll dive a little bit deeper. Semaglutide, also known as Ozempic, Wegovy, or Rybelsus. We know that Ozempic is approved for type 2 diabetes. Wegovy, that's the one that's approved for weight loss, and that's the one that recently came out with the oral pill, which is similar to Rybelsus, but like I said, it was at a higher concentration or a higher dose, so you have a more profound weight loss. The benefits that have been shown in trials is that in certain patients, it reduces the risk of heart attack and stroke. It can protect your kidneys and improves your blood pressure and cholesterol profiles, and can also reduce inflammation. Some of these medications are actually being studied for different diseases such as inflammatory bowel disease or rheumatoid arthritis, more autoimmune diseases that have chronic inflammation, because they're able to reduce inflammation in the body through several different mechanisms. So we may start to see the indications expand for this class of medications. So more people may be on this for reasons other than weight loss or diabetes in the future, which is very interesting. Tirzepatide is the newest GLP-1 that has been approved. It is that combination that we briefly touched upon. So the GIP is a glucose-dependent insulinotropic polypeptide. It's a mouthful, but basically it assists with insulin secretion. It also improves lipid metabolism. And then interestingly, it can reduce some of the nausea that can be seen with GLP-1s as monotherapy. And we'll talk a little bit about the side effects in a few slides, but it's interesting that this combination can actually reduce some of the side effects that GLP-1 receptor agonists can have on their own. This dual agonism has a more profound effect on weight loss. Some studies have shown up to 24% weight loss on this medication, which is just like an insane amount of weight loss for medication. And that was seen in combination with lifestyle and diet and exercise changes as well. So just keep that in mind that these medications are most effective when used with lifestyle changes. This medication has similar side effects to the other GLP-1s, but may have some less intense nausea, vomiting, diarrhea compared to the other medications. This is a blanket statement for all medications, but specifically for GLP-1s because there is some options to get this medication pretty much by ordering it online or through compound pharmacies, which is coming out of favor now with the new legislation. But it's always important that you should speak with a healthcare provider before starting these medications, even if you do have the ability to access it online without having a healthcare consultation. There are certain contraindications, like patients with these things should absolutely not take this medication. If you have a personal history or family history of a certain type of thyroid cancer, specifically medullary or MEN2 syndrome, and if you have not heard of this syndrome, you probably do not have it. It's relatively rare, but there are some concerns that it may increase the risk of developing that form of cancer specifically in those patients. So not a very common disease or disorder to have, but definitely worth noting. Also, if you have a history of pancreatitis, it is definitely used with caution or not at all in these patients because it can be associated with an increased risk of pancreatitis. And that's still undergoing some additional studies to see how strong the correlation is with pancreatitis because we think it may not be as strong as what it previously was published. However, for the time being, it's still definitely at least a strong caution with patients that have had previous pancreatitis, specifically if the cause of the pancreatitis is not known. So if you had a gallstone and then that caused the pancreatitis and you got a gallbladder removal, you may still be able to take it depending on your provider's comfortability. And then we do not have the data to approve it in pregnancy or patients that are breastfeeding. So for the time being, it is still considered contraindicated or a strong caution against being used in patients who are pregnant or breastfeeding. Some of the common side effects that you may hear about are nausea, vomiting, diarrhea, constipation, stomach pain. These medications are often related to the mechanism of action of the medications themselves. So if you can remember, we talked about how these medications work to slow the emptying of our stomachs. It's not that hard of a leap to think you're going to feel full longer. People will start to feel a little bit nauseous. They may vomit because that food is not passing through their stomach as quickly as it normally would. And because the transit time is decreasing, you can see constipation because that food is being stuck in your small bowel and large intestine for a longer period of time. So some people can also experience constipation from these. Fatigue and headache, these are general side effects that can be with almost any medication. And if you're having a lot of nausea and vomiting or having a lot of diarrhea and constipation, these can definitely cause dehydration, which can cause fatigue and headache as well. Some more rare but serious side effects are bowel obstruction. A more profound presentation of constipation and that decreased motility is a bowel obstruction, which means that food particles solidify. And then also because your bowels are not moving as quickly, it stops and it can cause a blockage, which can be very serious. Typically, patients are admitted to the hospital for this and they may or may not require surgery. It's a rare but a potential side effect. It can also cause some vision impairment in specific populations. So keeping an eye on your visual acuity and how clear your vision is very important. For patients with diabetes as a whole, they should be seeing a ophthalmologist or an eye doctor every year anyway, but specifically patients on GLP-1 should also keep a very close eye, no pun intended, on their visual health. Although it can be protective for patients with kidney disease, there is some concern that it may cause an acute kidney injury in some people. This may just be related to the nausea, vomiting, and diarrhea. So our body becomes dehydrated and our kidneys really need fluids to perform well and be healthy. So that could be a potential correlation to a kidney injury. Any medication or food can have some allergic reaction in some patients. So something that should be kept in mind. And then that questionable pancreatitis association that we talked about. These kind of contraindications and side effects are likely class effects meaning that most of these could apply to all GLP-1 receptor agonist medications. So just keep that in mind. No matter which medication you're on, you may experience some of these side effects to different extents. The benefits of these medications also may be class effects, meaning that you can extrapolate the assumption that some of these medications can also have cardiovascular and brain protection and kidney protection, even though they may not have FDA studies that shows that definitively, which is why if someone is able to get on a GLP-1 and it may not be like tirzepatide or semaglutide, I would still encourage them to, even though it may not have that FDA study that shows that there's a reduction in the progression of cardiovascular disease or the reduction in chronic kidney disease. It still likely has a positive effect on both of those organ systems. Some kind of practical considerations. So a lot of people, they come in and they say, I want the highest dose. I want to be very aggressive with initiation of these medications. And I totally get that. Patients who suffer from obesity and diabetes have been living with these conditions for a very long period of time, and they want to feel better as quickly as possible. But these medications can definitely have those side effects that we talked about. The risk of these side effects can be reduced by slowly titrating up the dose. Typically, your provider will start you on the lowest dose for likely 2 to 4 weeks to see how you tolerate that. Your body will get accustomed to having that exogenous GLP-1 in your body, and you can slowly titrate up from there. Typically between 2 and 4 weeks will increase your dose. And you should also have some dietary changes at this time as well, not just as a whole a healthier diet, but limiting high fat and greasy foods, encouraging a high protein diet, making sure that you stay hydrated because of those side effects that we saw. Eating smaller meals is also very important. Your body will tell you that you're full easier, so you should plan on having a smaller meal so that you don't go through food waste, number one, but also that you're planning your meals throughout the day so you do not have too profound of a caloric deficit, which is still important to maintain an adequate number of calories. So some people really have to work to continue to eat throughout the day, and some people will lose a dramatic amount of weight very quickly because they're really not taking in the amount of calories that they need. So it's important to plan your day out, encouraging smaller but frequent high protein meals that can help with some of those side effects. These medications, although they're very popular, they do have very good benefits. You likely will regain the weight if you stop the medication. So we know that between 18 months and 24 months after stopping the medication, it's been shown that you'll likely regain approximately the same amount of weight that you have lost. And that risk reduction in cardiovascular health and kidney health and stroke prevention also falls as you stop taking the medication. This is a very, very important consideration because insurance is constantly changing and people's access to this medication can vary. So we saw very recently that the government previously allowed compound pharmacies to produce this, so you could get it very accessibly online. And then more recently, when they said that there was no longer the state of emergency, or however the phrasing was, they no longer really approved the production from a compounded pharmacy. So millions of patients that were on these GLP-1s through a compound pharmacy lost access. And we saw from them that there was a rapid regaining weight. Their metabolic changes that had improved returned. So it's something to consider when on these medications. You'll likely need to be on it for a prolonged period of time in order to see sustained benefits, which I really do think is an important consideration. Resistance training is also extremely important. Please keep in mind that you're not only losing fat with this medication, you're also losing lean mass and muscles. When we think about weight loss, everybody thinks that we're just losing fat, and the fat loss is great because it does help our metabolic health as a whole, but we do lose lean mass as well. And it's important to come up with a resistance training program with your provider or physical therapist or whoever you seek your medical care from, and be consistent with this, because we know that patients that are on a GLP-1 that do not resistance train do have muscle loss. And as we get older, we know that muscle preservation is extremely important and can prevent things like falls or hip fractures or other bone fractures, things like that. So staying on top of your resistance training is extremely important when taking these medications. These are just some common questions that you should ask your doctor if you're not on one, or if you already are one. Ask, what are my indications for this medication? And then obviously, if you're taking it, you should know to an extent if your insurance is covering it or how much your copay is, and then which of the medications may be best for you. And then some even more exciting things are in the pipeline, or that drug discovery trajectory that we may see get FDA approval over the next few years. One is a triple agonist. So they're adding glucagon basically to tirzepatide, and this has even more weight loss, up to 24% plus weight loss. And this medication specifically can be very useful in patients with fatty liver disease or MASH. So it'll be very exciting when this medication finally finally gets FDA approval. It's already in phase 3 trials. Similarly, this other medication with a ridiculous name, orforglipron, which is an oral GLP-1. It's similar to semaglutide, but it's a different formulation. Also in phase 3 trials, showing about 10% to 11% weight loss. So there's a lot of different medications that are coming in the pipelines, which should improve the financial competitiveness between these medications. So we should start to see the cost come down in the future as more of these medications are available, and as companies that have like a brand patent, as those expire, these can be made in a generic form, which drastically will reduce the cost. So if you have talked with your healthcare provider and you have not been able to afford it due to having to pay out of pocket, in the near future, there may be options for you to do that in a much more financially accessible way. So I would continue to ask your physician if there's any updates regarding the costs that they're aware of, because the government is offering sometimes subsidies for it. So definitely continually check with your healthcare provider. Some key takeaways: just remember that diet and exercise remain the cornerstone of metabolic health improvement. All of chronic disease, including obesity, diabetes, chronic kidney disease, almost 80% of those chronic diseases can be prevented through lifestyle. So we really need to push for preventative interventions. Even if you do not have these diseases yet, it's important to try to make yourself as healthy and active as possible to prevent the development of these diseases in the future. All these medications that we talked about should be worked in with lifestyle changes and not instead of them. I'm not trying to be too redundant, but it really is important. So to keep that in mind. There's a broad spectrum of medications and pharmacologic therapy. So speak with your healthcare provider to see which, if any of them, are right for you. We know that GLP-1s are the newest thing that's very effective for many people. Ask about those, but also keep in mind it is a medication. There are some serious side effects. So speak with your healthcare provider. I hope that this has provided you with some information that you'll be able to more confidently speak with your healthcare provider or ask the necessary questions to see if you're a candidate for one or more of these medications. Just a quick note even about the commercials. Some countries prohibit that direct to consumer advertisements. Yep. So I have a love-hate relationship with commercials, because although it does get the patient more informed, it's really a lot of marketing that pharmaceutical companies are trying to get so that more patients are on their medications so that they're financially rewarded. So a lot of these medications may not be right for you, and you may still see these drug ads and you're like, I want that medication. But that's why it's just so important to speak with a healthcare provider before independently venturing to get one through like a compound pharmacy or anything like that.
Can metformin be used in addition to other GLP-1 medications?
Definitely. And a lot of these medications actually can be used in combination. Some of my patients that have very poorly controlled diabetes, or their A1Cs are very high, 15, 16%, more than 2 times what we're really shooting for. They're on GLP-1, they're on SGLT2 inhibitor, Jardiance or Farxiga, they're on insulin, they're on the metformin. We try to be as aggressive as possible for patients with uncontrolled diabetes or very high A1Cs to really try to bring that A1C down. Yes, you can definitely use these medications in combination.
Why don't insurance companies want to cover this? Because they have such benefit. You mentioned about patents. Some of these medications are really expensive.
Definitely. Think about it from the perspective of a pharmaceutical company. It can take billions of dollars to develop one medication. And a lot of these pharmaceutical companies, although they are multi-billion and sometimes even trillion-dollar companies, they'll try to develop a few different drugs. And let's say they develop 5 drugs, each of them costing $10 billion in development. 4 of those drugs fail, and then they only have 1 drug left that's FDA approved. They have to try to make that $50 billion whatever investment back from that one drug. So from their perspective, they want to try to milk the most financial opportunity they can while they have that patent, which I believe is 10 or 12 years through the FDA before kind of Joe Schmo can go out and recreate that medication. But while it's under a patent, they really try to accrue as much compensation as they are able to, likely for that reason. Now, they're definitely for profit. They're definitely not a nonprofit. So they're definitely incentivized to pay their employees well. Their board of faculty members that are on the boards of the pharmaceutical companies. So there's a few things that are incentivizing, but keeping in mind that there's a large amount of money that goes into the research and development of these these medications is likely why a lot of them are so costly. We do know that other countries do not have the same costs, which is interesting, but they know that the Americans will pay, unfortunately, for these medications. So even like Canada or Mexico or Europe, we see that the cost is different through each country's, regardless of their insurance, even paying out of pocket, the number can vary widely.
It's one of those things that reminds you of the system that we live in. But what you mentioned about the patents eventually expiring, so there's potentially more access in the future and lower costs.
Definitely.
If you need to be on the medications for life. So they are long term, and the benefits that you get if you stop taking it, like you said, you see those go away.
And then just another point on that, although that is a concern, some people are now talking about using the GLP-1s in combination, and this is not a novel idea, but in combination with bariatric surgery, or like a gastric bypass or a sleeve gastrectomy or an endoscopic version of these. So it'll be interesting to see long term, which is the most popular, because as of now, the gastric bypass has the most weight loss out of any kind of procedure that we can do, medication or not. But now some people are doing like a sleeve gastrectomy, which is where they remove part of the stomach to inhibit absorption of food and nutrients. And then after about a year, they'll start them on a GLP-1 and they'll see on continued weight loss. So it is interesting to see that it can be used as a tool in combination with other medical therapies and surgical options.
If diabetes medicine can stop working,
you'll see some patients that are on insulin, they may need to go up on the insulin. That can be from like insulin resistance, that topic that we touched upon, where your body doesn't react the same to insulin as it did before. So you need a higher amount of insulin. It's not uncommon to see that you'll need to go up in the dose of that. The other medications, patients typically will go up to the max tolerated or the max dose that we can prescribe, and then we'll move on to another medication. So it's like a step ladder. Their effectiveness probably remains the same, but getting to the point where your diabetes is controlled can take 3 or 4 medications. You can see them like all ramping up, but it's probably because we haven't gotten to the point where we're actually managing your diabetes. Now, if you're consuming a ton of sugar constantly, you can definitely see decreased efficacy.
Okay, so I know medullary thyroid cancer, your family having a history of medullary thyroid cancer was one of the contraindications for GLP-1s. Is there a way to test if you have that risk?
This is a very interesting concept because before the prevalence of GLP-1s, the thought about screening someone for a MEN2 so MEN2 is a multiple endocrine neoplasia type 2, I believe that's the name. And a medullary thyroid cancer is a side effect of having that disease. It can happen separately, but it's mostly associated with that disease. So screening for patients with MEN2, the utility of that is just not there. Generally speaking, before the use and wide implementation of GLP-1s, still the prevalence of that disorder is so rare that financially it doesn't make sense to really screen patients beforehand. And you most likely will know if you or a family member have had a history of MEN2. There's 3 classic manifestations. It's basically a combination of a parathyroid issue. You can get what's called a theo, which is a tumor that releases a lot of adrenergic hormones like epinephrine. Very profound symptomatic manifestations of this. So typically it's not a subtle thing. And even if you do have one of the variants, it's not necessarily meaning that you will develop medullary thyroid cancer, which is another reason why we could screen a bunch of people. They could have a genetic mutation that's associated with MEN2, but their risk of developing it is 0, and we don't really know that. So it would be difficult to appropriately treat those patients where their risk might be 0, but now we have this information and we don't really know what to do with that, if that makes sense.
There's not like a clear thing that you then would do. If there are any contraindications for GLP-1s for people who are on HIV treatment or PrEP.
The HIV medications and PrEP, like another version of the antiviral medications, those have a ton of drug interactions, meaning that you really need to monitor every medication, every supplement you take. You should definitely be speaking with a provider about. I believe that they are okay to take with HIV treatments from my knowledge. So obviously check with a provider, but I do not think that is a contraindication to take. Any kind of exercise is great. It's interesting though, because a lot of people don't know this, but postprandial exercise or walking after you eat actually can reduce your blood sugars. It's effective in reducing your postprandial blood sugar. So a lot of people will eat, You feel full, they'll go, I'm going to go sit on the couch and watch a movie. But if you're able to get out and do a 10 to 15 minute brisk walk, you can actually reduce your glucose spike after eating by 20% or even more. So very effective lifestyle modification without any kind of medication intervention needed. So walking is great. Any kind of resistance that you can add to walking. So if you have like light dumbbells or anything that has a weight to it, you can walk with those. Put a backpack with a couple books or something like that,
Like
just to
ankle
add
weights or
some.
something.
Rucking is the fad that's out now, where people wear like 50-pound or 100-pound backpacks and they go on
Wow.
like a 10-mile walk, which is wild, but it's effective. So anything that you can do to improve your activity level is definitely recommended.
If your diabetes is controlled, can you eventually stop taking medication?
If you're able to make significant dietary changes, I have patients that are on 50, 60 units of insulin a day. And then through working with a dietitian and work with endocrinologists, they're able to wean off of the insulin. And now their diabetes is diet controlled, meaning that don't need any medications to control it, which is amazing to see. And another reason why the lifestyle modification is just so important.
We did a pilot project that was with people who were living with diabetes, and it was so much about behavior modification and diet modification, and it was really successful. We've seen firsthand that can make a really big difference. It's great to have you reinforcing that for sure. GLP-1 patches on social media. Is that like a legit thing, or would you be skeptical about that?
I am not as well versed with those, so I don't want to comment incorrectly, but I'm not familiar with those. I will say that the patch trend has made its way on social media, and just keep in mind that a lot of the compounds that they're saying that you can take through a patch may not be like transdermally absorbed, meaning that our body is very good at protecting itself from absorbing certain things. So specifically compounds that have a certain reaction to fat, or like hydrophilic or hydrophobic, or lipophobic, they would not be absorbed through the skin. I'm not sure where the GLP-1 kind of compound lies on that, but I do know that there's a lot of snake oil salesmen out there that are saying that you can use a patch for about anything. Just definitely make sure that you look into the efficacy of, it's called transdermal absorption or something along those lines, before you make a financial investment into that.